Well, I think the essence of how to move forward here is to become more specific in how we define depression. It's a word that is general, has a lot of different meanings, and when you think about it from a clinical perspective, there really are many different types of disorders that might fall under that umbrella. So we really want to try and get to the specific type of depression so that then we can design a tailored treatment plan. Well, so the class word antidepressants, again, is a bit of a misnomer. These are medications that have very different pharmacologic actions. They all have effects in the brain on neurotransmitters, but vary from norepinephrine to serotonin to dopamine and to specific subreceptor types of those neurotransmitter types. So really what we want to think about is, does the patient have a disorder that has an underlying pathophysiology that would make it susceptible to treatment with one of these pharmacologic actions? And so as it happens, there's a great deal of overlap between the pathophysiology of neuropathic pain and what we think of as the brain disorder, major depressive disorder. So hence, we use both of these types of medicines to treat both disorders. When healthcare practitioners encounter someone who uses the word depression or who appears to be emotionally distressed, one of the things to think about is that this is a temperamental vulnerability that is being stressed in some way. And so, for example, the person that we typically think of as neurotic is easily overwhelmed in situations that may be provocative in a distressing sort of way, being told you have an illness. They don't necessarily react in a predictable way like the person who has a more stable temperament. And so they become somewhat catastrophic, somewhat unpredictable, and the healthcare practitioner finds them hard to interact with. Another temperamental trait that we often talk about is the introversion-extroversion spectrum. And introverts tend to worry, they tend to be punishment averse, they tend to think about the future and the past, and they're slower to engage with situations. So they need time and they need detail and they need an opportunity to process something. Whereas the extrovert is more likely to live in the moment, more likely to engage with an unfamiliar setting more easily, more likely to be driven by the promise of rewards rather than the threat of a bad outcome. And so if you think about those two classes of people, you can see how being sick, interacting with a doctor, having to follow complex regimens of treatment, that they might do some of that well, and yet they might be vulnerable to some of it, but it will appear very differently. Well, I think when it comes to motivational interviewing, physicians should remember that they spend a tiny fraction of their time with their patient. Even if they're seeing them once a week, which is unusual in primary care, it's 30 minutes or less. The rest of the time, the patient's on their own, so to speak, and they're doing whatever it is they're going to do. And so when it comes to managing their health care and following a regimen of treatment, you really want them doing that as best they can. And so the primary care physician, or really any healthcare practitioner, should be thinking about themselves more as a coach than a dictator. They cannot make the patient do things. They can only try to present the information in such a way that the patient recognizes that it would be worth making a change. And then they have to help the patient make that change and feel empowered to do so. So it's about listening to the patient. It's about asking the patient if they wouldn't or couldn't see a better way or a better outcome for themselves, and then asking them to just be willing to try things that then they will help them refine over time so they get more practice and more success. Well, I think in some ways it boils down to taking more time, but in a strategic sort of way. Giving the impression that you're disinterested, in a hurry, and already thinking about the next patient. It doesn't matter how much time you spend with the person. They'll know that, and they will not feel that you're working with them. On the other hand, to take just a few moments to sit down, to listen, to ask a couple of questions that give the patient an opportunity to fill the void, so to speak, and get out what is most important to them, oftentimes facilitates a more productive conversation about what you should work on right now, and then holding that in mind when you see the patient the next time so that the patient feels a thread going through their care. So catastrophizing really is an example of a coping style where patients feel helpless and overwhelmed and as if they have no opportunity to make a difference. And so we'll present in a way that feels as if they're spiraling out of control. It can be very stressful for a healthcare practitioner to encounter somebody like that because it can feel as if there's nothing you can do to calm them down and to keep them on track. However, there's a lot of evidence that shows that working with patients who are catastrophizers in very simple ways will greatly reduce their tendency to do that. So, providing them with education, talking to them about their illness and how you're going to manage it, trying to get them to think about improved support systems will all be effective and help to reduce that going forward. When it comes to grief, that too is an everyday experience for people. We've all suffered losses of one kind or another. And every healthcare practitioner is going to have to think about how the person who has a chronic illness is grieving the loss of their health and all that comes from losing that. So they don't feel as well, they don't do the same things they used to do when they were younger. Everything becomes a bit more of a chore, but yet it's a meaningful event for them. And as long as something is meaningful, there's the opportunity to change someone's interpretation of it. And the work in grief really is about helping people to see that it's not a disaster, it's not a failure, that there's still an opportunity to have a satisfying life and to experience some type of good going forward.